briefings. And today we're talking to the Minister of Health, Dr. Aaron Motsoaledi. Before the break, we're talking about NHI. We're talking about the legacy of the last 20 years of democracy and where we are in terms of our healthcare system. Well, we're going to start unpacking some of your questions, some of the issues that you're raising via Twitter, and also the audience that we have here. But just before we go there, what would you say if the healthcare system in South Africa was a patient? What are the vital signs that we have at this stage? What is the state of health?
Well, Peter, that was not defined by me. It can't be defined for South Africa only. It has already been defined internationally by the World Organization. I understand you to be saying, if there's a patient on a bed in the hospital, what are the vital things that we need to see? Yes, like blood pressure, temperature, the pulse, breathing, etc. The healthcare system is like that. And the vital signs that have been defined are 6 in number. Not by me, as I said, by the World Organization. It says, it calls them building blocks, rather. In the human being will say the vital signs that will make sure that this person is alive and kicking. For a healthcare system to be alive and kicking, you need 6 building blocks. The first is leadership and governance. The second is pharmaceuticals and other commodities. That's why this issue of pharmaceuticals is at the center, because it's a building block of a healthcare system. The third is the workforce, which we have already spoken about, the human resources. That's the third. The fourth is the healthcare financing system. I've already said it has been found wanting. That's why you need a new system like NHI. The fifth is healthcare information system. And the last is healthcare delivery system. What are the packages of delivery that the citizens of that country receives? So those are the vital signs.
So South Africa is the patient, South Africa's healthcare system is the patient. Are we in ICU or we are an outpatient?
Well, some parts will be in ICU. The fourth one I've mentioned, the healthcare financing system, will be in ICU because in South Africa, it favors only 16% of the population. That's 8 million people only. It leaves out completely, or in a way that is complete marginalization, 42% of the population, and that is 42 million people. That is the one we want to correct, which everybody says no, under NHI. That is the one which is in ICU. There's no question about it. The others will be between outpatient and the wards and all that. You know, for instance, the issue of workforce. I've already told you it's a worldwide problem. The shortage of 4 million people, which is critical in sub-Saharan Africa. So that one, I won't say it's in ICU, but it's a very big problem. The first one about leadership and governance. I've already told you that there's a decade on which we made mistakes by assuming anybody can just be a leader inside the healthcare institution. And we are looking at that. You are aware that we are reappointing CEOs afresh. We are training them. We want them to have a background. We want this issue of leadership and governance. And the governance part is happening sporadically. It's not like in schools. We want to move to a system whereby, just like in schools, a hospital and a clinic has got a board and a governing body, which is recognized by law, which has got powers to act when there's a problem. That is the part that we are still planning, because education has been able to achieve that. Everybody knows there's a school governing board with a chairperson who has got certain powers in the school. In our healthcare facilities, that is happening sporadically.
All right. We're going to unpack a lot of these things via our questions, and let's go straight to our tables now before we run out of time. And we'll start at table number 11, and that's Shelley Carey. Shelley Carey, table 11.
Minister,
yes.
I would love to know, is there the implementation of NHI, is there a political will to drive that, considering the enormous costs? Becomes a hot topic around election time, but is there actually a will to drive that process? Thank you.
Okay, so is this electioneering that we're talking about NHI at this time, or are we going to get the job done?
I'm not sure what you mean by electioneering. We started this thing long ago. Actually, to answer you, no country has been able to put up this system without political will. It's a political decision. There's no question about it. Without political will, it can't be implemented. Peter, this is not electioneering. It's a reality. And it's not a reality that is starting now, lest people forget. I told you it's in the Constitution. I belong to the ANC, I come from the ANC, which comes from the Congress tradition. Go and look into the Freedom Charter in 1955. There are 2 lines on the Freedom Charter about this issue. Under the heading, there shall be security, housing, security, and comfort. The 2 lines are: number 1, it says a preventative healthcare system shall be run by the state. That's number 1. Number 2, it says a free healthcare system, including hospitalization, must be implemented with special emphasis on women and on pregnant women and children. You remember Madiba tried to do that, taken from this, when he declared free healthcare for pregnant women, for children under 5. What was lacking then, as we look back, was the issues you asked me about. Will there be equality? And that's the plans I'm saying we are working on now.
Okay.
So there is political will, but also this country has adopted the NDP, Vision 2030. Go and look into the NDP, what it says about health. It simply says a national health insurance system must be implemented in phases with relative reduction in cost of private healthcare, held by human resources and proper healthcare system. That is what Vision 2030 said. So I've got no option. These are not just choices I'm making. They are written there in our documents and in our consciousness.
All right. Barnabas Kulu, table 14. Barnabas Kulu.
Thank you, Peter. Sorry. My question is directed to the minister. Minister, what kind of plans do you have as a ministry to deal with a huge backlog of examining the ex-miners
I'm missing that.
in this country?
Ex-miners, I'll tell you now.
In this country, which are based across the length and breadth of this country and in the neighboring states, I mean Lesotho, Zimbabwe, Mozambique, and Malawi. The reason why I'm asking these questions is because I'm involved in a case which clearly indicates that thousands of them don't have access, and the medical bureau is not effectively assisting them.
All right. So we're talking about miners who've fallen sick because of years of mining here in South Africa. Some of them are from neighboring states. So if I understand the question is, what are you doing to make sure these people get taken care of?
Yeah, that's a very good question. It's coming at the right time. On the 25th of this month, we are having a big conference hosted by South Africa, but convened by the World Bank, the Global Fund to fight HIV, AIDS, TB, and malaria, and the Stop TB Partnership, which you know I'm chairing. That conference is going to bring ministers of health in the whole of SADC, ministers of mining, ministers of labor, ministers of finance. We have already written them invitations. We are already preparing. We are going to sit with the mining sector. The deputy president has already called a meeting early this week, where the mining sector, the Chamber of Mines, attended to discuss this issue. When I leave here, I'm going to address NUM about this issue. They are waiting for me at 9 o'clock. I'm going to address them about this issue because it's a reality and it's very painful. What happened to mine workers in this country and what still happened to them. So we're going to sit together in that summit. What are the outcomes of that summit? We want 3 outcomes. One of the biggest problems that you are talking about that is killing them is TB. Mine workers are 7 times more susceptible to TB than ordinary citizens. And many of them have just suffered and gone home and, So what do we want SADC to do? We want 3 outcomes. Number 1, we want a common treatment protocol for the whole of SADC, in as far as this is concerned. Number 2, we want a common database of all those miners. I must press a computer, whether I'm here or in Lesotho or in Mozambique, I must press it and know about where they are and what are they doing and who they are they and what's happening to their families. Number 3, we are going to discuss common referral processes. The last one is talking about this compensation. Yes, the issue of compensation has been a big problem also. The compensation commissioner is already part of this process. We want in fact, we need a new act. There are lots of acts all over the place in health, in labor, in mining that deal with this issue of compensation. For the past 24 months, we've put somebody, a specialist in occupational health, who's pulling all those things together and is about to finish. We might find ourselves having a new act about compensation.
Right. So what timeline can we give him where we can say SADC miners will be taken care of from this day?
We are inviting you to that conference.
Yes.
We are inviting you to listen. That's why we are not calling, it's not a health issue only. It's an issue that involved health, mining, labor, even finance. Okay. That's why we are calling all these 4 ministers. All of them have received letters. In fact, we are sending, as I'm speaking, there are people who are running around SADC, even visiting them to prepare for that conference. We believe SADC must get rid of that problem once and for all.
And that's the 25th of March.
Yes.
Okay, a tweet has come through, and this has been representative of quite a number. Mushibudi Patulwana says, what are you going to do about long queues, unavailability of medicines, nurses' attitudes, as well as the lack of doctors? I think the staffing, you talked about doctors, but this attitude thing, I don't understand. The nurses are there, they've got a job. There must be something that's causing them to be like that. What is it? How can we fix it? And why are they being like that?
Well, yeah, I'm going to come to the long queues because it's very important. This issue of attitude of staff, Peter, the last time I was here. I think we discussed it, I need to remind you.
Yeah.
But we've already done an audit in 2010. We did an audit of all the health facilities. We audited about 3,900 facilities. Round about there. Where we're looking at cleanliness, attitude of staff, infection control, safety and security, drug stock out, long queues, waiting times. We've got results. I'm in a position to show you what each and every one of these 3,900 facilities scored. In terms of figures, we do have that. And of course, we picked up from there that on this one standard, we call them core standard, attitude of staff, it was found wanting. It's quite bad from what we have seen. And people are saying it's not only in public hospitals, even in private hospitals, they do meet this attitude. Only that because there, in private hospital, there are rich people. It's better. Because when you deal with a rich person, you become careful. But when you deal with the poor, you don't care. That is one of the issues. So we have examined them. Yeah. We have called the nursing summit to examine them. One of the things we have done is to open a special office called the Chief Nursing Officer. That person took the work is Dr. Nondlandla Makanya, who is a nurse by profession. And she has got the doctorate in nursing. And she has been in this area. She was once the president of the South African Nursing Council. She is now running that office. What should we do? What should be the ethics of nurses and how should we train them? One of the problems I identified, and I might differ with people, it started in 1984, this problem. Why the attitude has changed. It started in 1984, 10 years before democracy. What happened? In the past, Peter, when you want to be a nurse, you pass matric, get into the nearest hospital, knowing nothing. You are going to start training inside the hospital, in the ward. You are going to start by cleaning somebody who has soiled themselves. You are going to start training somebody who can't tend themselves. You are going to feed somebody who can't feed themselves. You are going to wash somebody. That's going to be your work. And you are developing that compassion with patients. You believe this is what you came here to do. By the time you read big books and start knowing big medical terms, you have already...
The bread and butter of the work, you know.
Yes, we have already cleaned people and all that. In 1984, that curriculum was changed in favor of universities, where people wake up from home and get into a university lecture hall. And you know, when I talk about this thing, because it's sensitive among some nurses, but I'm a very open guy, I will absorb whatever blows I get from them. If you look at our nurses, during my time, nurses who were trained in this manner, I starting by cleaning people, etc. When they've got 4, you know, nurses like, I mean, they've got bars here. When they acquire those 4 bars, starting with the green one of midwifery, etc., they will have had 7 years of training by the time they acquire the 4th one. In the new system that started in 1984, that doesn't start with cleaning a person inside the ward. It starts with academic lectures in a university lecture hall. You spend 4 years, you get all the 4 bars. 3 years of training already completely cut off with no practical training, but which is done sporadically when you visit a hospital. That's what happened to this country. From there, private nursing companies took over because there's a gap which has been opened by the state. Because I regard nursing as a practical subject. Like, let me give you an example. I know you want to come in. Like a policeman. If you want this country to collapse, start training policemen in a university lecture hall at the university. They all start at the ground there.
Okay, but
or if you want your army to be defeated, start training soldiers at in a university lecture hall, not in the bush. But that is what we need to change.
Isn't it about, there must be, it could be working conditions that's demoralizing them?
I'm giving you factors, not one.
Yeah.
I'm starting with the biggest one.
All right.
The working conditions also demoralize. I'm painfully aware of that, including this issue of working in a hospital that is dilapidated, etc. I've seen that. And for that, I'm just giving you the whole picture.
Yeah.
For that, I'm not blaming the nurses. I'm taking the blame. And that's why I'm putting together processes on how to solve it. And by the way, I've seen it in practice. I've seen it. I visited one hospital that's being renovated to brand new status, and the CEO was surprised because it was an 8-story building and they were starting at the top. He said the stories that have been renovated with equipment, with everything, the attitude of nurses there has improved markedly. Yes, because if you put me in a situation where the building is collapsing, there's no equipment, etc., my attitude will change. So I'm giving you where I think the problem has started. You are telling me what makes it worse.
Yeah.
The other thing that will also make it worse is the fact that the public sector and the private sector are sharing the same nurse in the country. A nurse works for the whole day in a public hospital. Instead of going to rest like all of us, every human being has to rest, they now go to the private sector to work for the whole night, something called moonlighting. And of course, in that private sector, because they are rich people, they smile all night. And they get very tired of smiling. In the morning, when she wakes up and go to a public hospital, the first poor person she gets there is an irritant, you know. She's tired. This person is irritating you. What does she want here? Why is she coming here? She's been here last week. The fight, you know. All those problems have also been identified in the Nation Summit. This moonlighting of nurses, is it good for the country? It is bad. I've spoken to some people in the private sector who said, Minister, it's not only you, even with us, because they say, by the time they come to us, they are already tired. Right. So this issue of sharing nurses...
if we paid them well, they wouldn't have to.
Well, I don't want to come and lie to you, Peter, because these are realities of life. Nowhere else in the world does the public sector ever pay like the private sector.
But maybe
I don't know a single country where that is happening.
But maybe we should lead the way.
By
Because
doing what?
By paying them well, because it's
No,
such a vital sector.
The OSD was trying to do that. It has got problems. All I was telling you is that there is no country in the world, unless you can put it here and show me, that in this country the public sector is able to pay more than the private sector.
Why don't we become that country?
I don't think it's ever going to happen in any part of the world.
No,
the private sector
forget
always,
the rest of the world.
the private sector always in terms of resources, because it serves very few people. It's for a selected few, not only in health, in all sectors of life. The private sector will
But
always
I
pay
think it's
better.
not so much that you have to pay as much, but close the gap, maybe.
Of course, yes, absolutely.
Yeah.
No, that one I'm not rejecting. What, as I said, OSD was trying to do that. All I'm saying is that there is no time in history where they will ever be at par. Not only in health, in all spheres of life.
Okay.
You can go to education, you can go to what? The private sector, because it's always for a selected few who have got a lot of money. It will always be having more resources.
Okay. Table number 7, talking about resources. Lebogang Shole. Table 7, Lebogang Shole.
Thank you, Peter. Thank you, Minister. With regards to the health infrastructure, you previously had announced there were plans to build 6 new academic hospitals, basically through a public-private partnership. These being George Mukhari, Nelson Mandela, Chris Hani, you know them, Limpopo and Nelspruit. When do you plan as a national department to go out on tender for these? As you know, TAs have already been appointed.
What is the question? When
do you plan to go out on tender for the construction of the 6 new tertiary hospitals?
When?
Yes. When's the tender coming
Because
out?
When is the tender coming out? No, I don't have an answer to that, because that's a huge project that is not only run up by us in health. It's a project that is being prepared by Treasury, the Department of Health, and the DBSA, the Development Bank of Southern Africa. They are sitting together. If I'm not mistaken, they were having a meeting about that this week. So I can't answer it. I'm not yet ready to answer that question.
Okay, all right. He's deferring on that one.
Yes.
Keba Maleka.
Yes, just keep your tender application ready. We will announce, because I know that's exactly what you want to know.
Just get your BE certificate ready. Keba Maleka tweets and says, how far are we with an AIDS vaccine?
AIDS vaccine?
Yes, how far are we there?
Well, I don't know how many years, but you are aware that early this week, was it last week or this week? Last week.
Yeah.
We made, scientists here in South Africa and the United States made very serious inroads. And maybe that's the question the person wants to ask. They found a woman under Caprisa in Vulindlela project in KwaZulu-Natal who produces what is called broadly neutralizing antibodies. You know, when you have got HIV and AIDS or any disease for that matter, your body produces antibodies to fight that disease. And when we give you a vaccine, we take that dose, we give you the disease artificially, and your body produces antibodies. Next time when the real virus or bacteria comes in, it fights it. That's what the vaccine does. Now, scientists have been groping in the dark in looking for a vaccine. But after this discovery in KZN, where this woman produces antibodies that are neutralizing, others broadly neutralizing, other patients, 80% of HIV sufferers, the antibodies they produce are not broadly neutralizing. It means they are weak and they kill very few viruses. Hers are broadly neutralizing because they've tested viruses from all over the world, from China, from America, from Europe, from the rest of Africa. That women's antibodies will kill them. The second thing, they've been able to clone. They can manufacture those antibodies in the laboratory. They are busy doing so. And after that, the next step, I understand, is to do animal tests now. That means take it to animals. They are going to test it with monkeys and see how it works.
So we're still quite a way away.
That will take about 3 years. The second step is to move to, their phases. That will take about 5 years. So we are not less than 10 years away.
We'll
I
have a
can't say
picture.
so. At least
We're
count some
closer.
10 years if you follow that course of those antibodies. But I must warn, anything in science can go wrong. You
Okay.
can find that path somewhere in the middle, something happens and scientists tell you we can't go
The
on. But at the
virus
moment,
changes
we're there.
its fine.
Yeah.
All right. Okay, we're going to take a quick break and then we'll start to, we'll continue to ask a few questions on that because there's, Mashaman is worried about this circumcision story, reducing HIV and the way people are interpreting it, but we'll unpack that right after this.